Welcome. Today's topic is understanding the treat-to-target approach and effective partnering in managing your IBD. My name is Mark Matar. I'm Associate Professor of Medicine at MedStar Georgetown University Hospital, the Program Director here at the Fellowship Program, and also the IBD Center Director. These are my financial disclosures. So today's goal is to develop an overview of the treat-to-target approach and effective partnering between patients and providers for successfully managing inflammatory bowel disease, or IBD. So let's think about the evolution in IBD management. First, the old way of thinking, how do I feel today, fixing my symptoms that are happening now, tailoring my treatment to my symptoms. And then now this treat-to-target approach, or the new way of thinking, which is thinking about what is my risk of developing a complication in the future. I need to tailor my treatment to my disease activity, genetic makeup, and risk, and possibly being proactive versus reactive. But what is treat-to-target, and how does this involve precision medicine? Treat-to-target is improving care and outcomes by targeting specific patients and clinician treatment goals, then monitoring the progress towards the treatment goals. What result do the patient and provider want to see happen to improve disease outcomes? So how do we get there? We get there with precision medicine, which is tailoring treatment plans based on individual patients' IBD history, genetic makeup, and disease severity, rather than using a one-size-fits-all approach. The concept of treat-to-target must include the following. There's a target or end goal decided by the patient and the provider, a way to measure if the target has been achieved, and treatment plans that make it possible to hit or achieve the target. Let's look at some examples of targets. So it could be a single target, a moving target, or multiple targets. The target can be different between patients depending upon age, stage in life. For example, pediatric, geriatric. Are we working through getting through class schedules and homework? Are we getting through jobs and work? Type of Crohn's disease or ulcerative colitis is someone dealing with strictures or narrowed areas in the bowel, abdominal pain or different symptoms, disease activity, how severe the disease is or how active the disease is, disease severity in terms of complications, and even things called fistulas or abnormal connection, a patient with Crohn's between bowel and other parts of the body. Symptoms outside the gut. Some patients could have rheumatological abnormalities, joint pains, things like that. Health literacy, how well do we understand the disease and progression along with medications we're using, and pre-existing conditions. Do we have diabetes? Is that going to affect how we look at different medications and side effects like steroids? Let's look at different targets to consider when looking at treat-to-target, going from the outside in to more specific and deeper remission, what we call it. From the outside, we look at improved symptoms. That is the least type of target we need to get, so the lowest common denominator. And clinical remission, so patients feel good and symptoms are under control. Getting into steroid-free remission, and then even deeper at mucosal healing and histologic remission. We'll talk about what these means in the next slide. So again, let's look closer at these targets, possible targets, and why do we aim for these targets? So again, going more superficially into deeper remission. First, improved symptoms. So some of the symptoms may be there still, while some of them are improved. And this will help with improved quality of life. Just like clinical remission, when you control all the symptoms, this also will help improve your quality of life. But then we go a little further and try to remove steroids from our treatment plan to achieve no symptoms along with not requiring steroids. This is going to help quality of life, but also decrease complications from IBD and potential toxicity that we will discuss from long-term steroid use. Some other possible targets and why we aim for these targets. So first of all, mucosal healing is when your provider performs a colonoscopy and actually looks for ulcers or bleeding or active disease from the Crohn's or colitis. And we want to see those ulcers disappear with appropriate therapy. Once we get to that point of mucosal healing, then we can actually reduce risk of complications down the road. And then we have the ultimate goal is histologic remission, which is the microscopic healing of the bowel when you take biopsies during colonoscopy and the pathologist looks under the microscope and sees the actual cells and the lining of the gut healed up. And that is evidence of no evidence of active disease. And that is slowly potentially becoming one of the goals of therapy. When assessing targets, there are some things to keep in mind. When you only have symptom control or clinical remission, this can be associated with a higher risk of flaring and treatment failure compared to if you had actual mucosal healing or endoscopic healing and histologic microscopic remission. If you have mucosal healing and histologic remission, this has been associated with longer symptom-free periods, less risk of flares, less surgeries, less use of steroids, and less hospitalizations. And to achieve mucosal healing, histologic remission may require long-term immunosuppression or combinations of immunosuppression medications that can lower your body's immune response. So some treatment guidelines to look at. As everyone's personal goals, preferences, and targets vary, so will the treatments. In IBD, it is not always one size fits all. We have some guidelines to help guide us from the American College of Gastroenterology and the American Gastroenterology Association for treating Crohn's and colitis. But again, these are just guidelines as a scaffolding to think about how we treat patients with IBD. But we have to look at every patient individually and what their needs are. Let's take a look at a couple of examples of treatment goals, looking at two examples of patients. Patient number one will be a goal to reduce steroids. Say this patient has diabetes and their blood sugars can go up. They've been on steroids or say prednisone for 2 or 3 months. Even though their symptoms from their ulcerative colitis, for example, are under control, they can still have thinning of the skin or more infection, or something that's being caused by the steroids. We want to remove the steroids in a safe manner. So we have to talk about a plan to taper the medication, meaning taking smaller and smaller doses over time in a safe timeline, assessing how a patient is doing, and determining next treatment and evaluation step. And then another example, if patient is not under control, say if they have Crohn's disease and having a continuous abdominal pain, the goal would be in active Crohn's to treat possibly with a new biologic agent because the current medication is not working. So we'd have to consider monitoring for side effects of these new medications, evaluating symptom changes, assessing, again, mucosal healing, maybe colonoscopy, histologic changes, and discussing results and evaluating. There are a variety of medications to consider in treatment plans. Here's a brief rundown of the different types of medications your provider may consider. Aminosalicylates are used to treat mild to moderate episodes of Crohn's disease and ulcerative colitis, more useful as a maintenance therapy in preventing relapses of the disease. They work best in the colon and are not particularly effective if the disease is limited to the small bowel, like we see in patients with Crohn's disease. Immunomodulators, there's medications like 6-mercaptopurine or azathioprine. These are oral medications that modulate or suppress the body's immune system response so it cannot cause ongoing inflammation. They're also helpful when used together with biologics to decrease antibody formation, and we'll talk about that a little more. Biologics are antibodies grown in the lab that stop certain proteins in the body from causing inflammation. These are usually introduced via the vein, intravenous form, or the skin, sort of subcutaneous form. Biosimilars are nearly identical copies of other already approved biologic therapies. JAK inhibitors, they're molecules of oral medication that suppress your immune system by blocking the specific enzyme called JAK and preventing it from activating the specific immune system cells that cause inflammation. These medications taken orally are FDA approved to treat moderate to severe ulcerative colitis, and more studies to come for other indications, hopefully in the future. Corticosteroids, or steroids, suppress the entire immune system and are used in the short term to treat moderate to severe active Crohn's disease and ulcerative colitis. So let's look at understanding the role of steroids and some side effects. So the different types of steroids, and our body handles these steroids differently, and this is called bioavailability, how much of the drug is circulating in the body. So some of them have high bioavailability, meaning the body actually can have adverse effects and positive effects on different parts of the body. Prednisone or intravenous methylprednisolone, like if you get admitted in the hospital, you may experience this medication. Some medications don't distribute throughout the body as much as the other medications, like prednisone. So this would be budesonide and different forms of budesonide, oral or budesonide rectal foam enemas that you may have seen. These medications are to be used as a temporary measure, not long-term. Why? because of its impact on body and mental health in a negative way, and serious other side effects and complications with stopping abruptly. So you definitely want to talk to your doctor about appropriate tapering, or as we said before, decreasing the medication dose of steroids at a slow rate so your body does not become dependent on this and cause side effects. And just some examples from this diagram of some of the potential side effects of long-term steroid use: emotional disturbances, cataracts, pancreatitis, or inflammation in the pancreas. Ulcers can become worse in these patients, muscle weakness, loss of muscle mass, just to describe some of the side effects. In addition to medical treatments and procedures, patients often consider diet and complementary therapies to help them reach their personal goals and targets. Diet can be considered part of your treatment plan. It can be improved symptoms, and research may indicate it improves inflammation. So this can include changing the microbiome, changing the different bacteria in the gut to a more healthier microbiome, changing in the mucus layer in the gut, or what's called intestinal permeability. So there's this feature, some called leaky gut, where the barrier between the gut and the blood cells is disturbed, and that's where some of the bacteria can go back and forth through that barrier and cause a cascade of cells to cause inflammation and drive inflammatory bowel disease. Some of these medications can help close up those gaps and help with the mucosal layer, the protective layer in the gut. And some of the dietary therapies can also help with this. Diet can be considered as a therapy for IBD, which is what's called enteral nutrition. So there's, in pediatrics especially, some formulas that these patients can take that could help with the mucus layer that's protective in the gut and help with their IBD specifically, especially in Crohn's disease. And other physician-approved diets like the Mediterranean diet or specific carbohydrate diets and low-sugar diets, these have been shown in some studies to potentially help in a complementary fashion with medications to help with the Crohn's or colitis. There's also other complementary therapies to consider, like mindfulness techniques, exercise, and stress relief. Now let's look at measuring targets. So there's different ways to measure the targets we're looking at. So we want to understand diagnostics versus prognostics, endoscopic procedures, radiological scans, and diagnostic and predictive biomarkers. So what do these all mean? Let's get into this. Diagnostic tests are used for the purpose of making a clinical decision, such as a diagnosis. Is this ulcerative colitis? Is this Crohn's disease? Where is the Crohn's disease? Is it in the small intestine? Is it in the colon? How severe? Prognostic tests are used to predict a patient's likelihood of developing a disease, severity of disease, or complications from the disease. Some of the diagnostic procedures include colonoscopy, sigmoidoscopy, upper endoscopy. Those are probably the main ones used for Crohn's disease and ulcerative colitis. But then if it's in the small intestine only, sometimes we need to look at further imaging like MRI, or what's called MR enterography, which is a special kind of MRI. Examples on the right there of image there. Or video capsule endoscopy, or a pill with cameras on the end of it that you could swallow and takes pictures going down the small intestine to help look for these ulcers or areas of inflammation that could be indicative of IBD, especially Crohn's disease. What are some other blood and stool tests that we look at as biomarkers? So biomarkers are characteristics of the body that can be measured. So in IBD, there are blood and fecal biomarkers below. Blood biomarkers include CRP, or C-reactive protein, and erythrocyte sedimentation rate, or ESR, sometimes you hear it as SED rate. These are very predictive of active inflammation in the gut, but they could also show inflammation anywhere in the body. So these are blood tests, but if you have the flu, or if you have some infection or joint pains or arthritis, these will also go up. So we have to be careful. So if we want something more specific, your doctor may order stool tests to look specifically at gut inflammation. And these are proteins that are in the gut specifically. So fecal or stool calprotectin and lactoferrin. Lactoferrin is a little bit cheaper than calprotectin, but these are both available to test for gut-specific inflammation by looking at your stool. Now let's look at how every individual's body reacts with these medications that we use. And this is called therapeutic drug monitoring. It's the measurement of specific drugs at timed intervals to maintain a relatively constant concentration of the medication in the blood. We want to make sure these medications we use keep a nice baseline level in the blood to keep its effect for anti-inflammation for the IBD. So, for example, if your physician puts you on 6-mercaptopurine or 6-MPA azathioprine medication, we're going to test TPMT, enzyme activity in your body, make sure it's not too high, not too low, really for the safety and develop a good dosing regimen for you. And with the same medication, while you're on this medication, we could check the sort of the byproducts or what the 6-MP gets broken into. It's called 6-TG or 6-MMP. We could check these levels in your blood and see, do we have enough of what we want? So the active sort of ingredient, which would be the 6-TG, we want that to be at a good level. And we want the 6-MMP to be kind of low because that could cause some problems with low blood count and things like that, and liver enzyme abnormalities. There is another interesting test that we're going to start using more frequently called HLA. This is a genetic test, DQA1. If a physician is thinking about starting a medication, a biologic called infliximab or adalimumab, this blood test is very unique, and it could actually test ahead of time to see if you're more prone to having antibody formation against these medications we're trying to keep up. So, for example, if you start infliximab on a patient with a gene that's not mutated, that's healthy, this patient would have less chance of the infliximab level going too low. And the infliximab would have a good effect, good level in the blood, an effective level, keep it at a good baseline, and should be able to control their IBD better, rather than someone who has a mutation in this gene where the body can make antibodies against infliximab and drive the infliximab level down to almost undetectable levels, and then therefore cannot have its effect for anti-inflammation. So a lot more to come, a lot of research going on with these different tools. Biomarkers that characterize types and prognostics of IBD include these three main ones, then we'll talk about some panels. So there's a blood test called p-ANCA, and it's associated more with ulcerative colitis. One called ASCA, which is associated more with Crohn's disease, and some other ones from bacteria actually in the gut called CBER1 and OMP-C. And these are associated with worse outcomes of Crohn's disease. These patients could have more complications from Crohn's disease, like I mentioned before, the abnormal connection, the fistula, the narrowing or the stricturing disease, and abscess or pockets of infection. So there are different test panels that are also available that kind of include these tests along with others. And these include what's called IBDX, which can be checked at LabCorp. This aids the diagnosis of IBD versus non-IBD, like maybe irritable bowel syndrome or other types of diseases or symptomology. And for Crohn's versus ulcerative colitis, again, they can incorporate ASCA and CBER and all these different biomarkers, as well as for predicting the probability of Crohn's disease progression. Another test by Prometheus called Monitor, and this can assess mucosal healing by evaluating blood tests of 13 biomarkers in patients with Crohn's disease. It has about 90% accuracy. So this is sort of, if you look at CRP or C-reactive protein in the blood, this may be a little bit more sensitive in this patient with Crohn's disease, almost like a fecal calprotectin, but it's a blood test. So I'll think of it as sort of a blood test that's almost equivalent to fecal calprotectin for gut inflammation, especially in Crohn's disease. And again, more of these types of panels to come. And the Crohn's Colitis Foundation is definitely building partnerships, universities and commercial, to advance the development of such testing and IBD biomarkers. Look at some scenarios, 3 scenarios of where we are now, maybe even the past, and looking into the future of prognostics and personalized care. So in a patient scenario, say the year 2000, patient with Crohn's of the small intestine on infliximab, standard dose with right lower quadrant pain. Colonoscopy looks normal, including the small intestine or the ileum. Patient has continued pain, admitted to the hospital, and found to have an infection or infection pocket or an abscess from an inflamed small tissue. Unfortunately, this patient will need to go to surgery and then restart it on infliximab shortly after surgery. Sabi's scenario, sort of in 2000, looking just at clinical remission. How about maybe year 2015, adding some more tools? So say this patient with Crohn's of the small intestine on infliximab, standard dose. So same patient presents with right lower quadrant pain. Again, colonoscopy is normal, but now we add MR enterography, or the special MRI. And this reveals a thick-walled ileum where colonoscope could not reach. Now we can make a change. We check infliximab levels or concentrations, and they're low. C-reactive protein is normal, but stool calprotectin was elevated, so it caught that inflammation. So now we could give the patient a higher dose of infliximab, pain is resolved, and repeat MR enterography and calprotectin are normal without requiring surgery. Now let's go a little bit further into the future and add some more tools. Now this patient, say we catch him earlier, newly diagnosed patient with Crohn's disease of the small intestine before any medications. Now what if we get those, what's called the monitor labs, and they reveal high-risk Crohn's type, CBER1, and OMP-C positive. So again, this is sort of the high-risk Crohn's type. So patient initiated on infliximab, so that's what we did before, right? But now we add therapeutic drug monitoring after the first few dosages, or what's called the induction. So we're being proactive about this, not waiting for symptoms. Infliximab blood levels are not optimal, they're low, and then we could increase the dose. Repeat levels are optimal for infliximab. Then you do a normal colonoscopy. Even if the patient is asymptomatic, no symptoms, look at the colonoscopy, the MR enterography is normal, the C-reactive protein and calprotectin are normal. Again, we're checking these even without symptoms. Routine C-reactive protein, calprotectin, and monitor labs with occasional colonoscopy and MR enterography really help this patient get on the right medication, the right dosage, and modifying earlier before even thinking about surgery or patient getting into complications. What if my target is not reached? What are my options? So first, you want to review the external factors. Are you taking medications as instructed? Are you unable to take the drug recommended due to problems with insurance or finances? Is your school or work schedule impacting your treatment plan? Also look at adjusting treatment. You may need to change your treatment plan. Perhaps treatment simply isn't working. However, keep in mind your IBD history, especially previous treatments that you may have been given in the past. Additionally, keep in mind the risks with adjusting treatment regimens. You want to think about switching medications. Possibly antibody formation could occur when you switch too quickly, and financial limitations. Does insurance cover the adjusted treatment? And you also want to potentially modify your target. You may need to change your target. If meds aren't working, you may need to adjust expectations and think about more attainable goals. So this concept of treat to target can be new to many. So let's now take a look at two surveys and work groups that the Foundation has worked with to see what patients think about treat to target. IBD Chorus is the Crohn's and Colitis Foundation's national initiative to improve the quality of care of IBD patients. We surveyed 100 patients at Chorus sites across the country to better understand their top goals and concerns regarding treatment of their disease. And we found these three main goals that our patients were concerned about. One was understanding the type of concern that patients would like to address in clinic visits. Two was trying to quantify the frequency of different types of concerns from IBD patients. And three was identifying predictors for IBD patients' concerns. So again, we need to look here and highlight that patients may have different goals from their physician and have that communication between the provider and the patient about the different goals. So looking at this chart here, if you look at symptoms on the left, the main goals for the patient were maintain level and prevent future symptoms. And then specific symptoms mentioned were pain and urgency and some others. Psychosocial and quality of life. To the patient, what was important to them was effective IBD on daily living in terms of travel and work and daily activities. And then you got to look at fear and worry and different potential concerns. Also, clinical course and management. So in terms of clinical course, patients are very concerned about family planning. Could I have a healthy baby while I'm on this medication? Or if I'm flaring, different types of medication changes or modification, or even nutrition or dietary changes. In terms of management, access to care was a big concern. In terms of medications, concerning mentions were if the medications had side effects, and especially if the medications were not effective, patients felt sometimes they just were still having breakthrough symptoms with the medications. So these are all examples of some of the goals and concerns that the patient had. In July of 2020, the foundation conducted 2 online discussions with a total of 12 patients and caregivers regarding their knowledge and interest in the treat-to-target approach. When patients and caregivers were asked to rank their top 3 personal IBD goals, term medical, example, reduced inflammation, no surgery; physical, fewer symptoms; and social, able to see friends, go out to dinner; and emotional, actually just feel happier. The medical and physical goals were ranked the highest goals for personal IBD health, followed by social goals. Even with a good rapport with providers, slightly less than half of the participants were not aware of the treat-to-target approach, although overall most indicated a willingness to use it or try it out. The majority of participants identified mucosal healing as the most important target. Remember, this is from the colonoscopy results. They expressed a desire for a better understanding of research behind mucosal and histologic or microscopic healing. And affordability and insurance coverage were mentioned as a challenge for achieving goals. Goal setting and effective partnering. So you want to set your goals alongside your health care provider. Effective partnering. Discuss your personal preferences. Consider short-term goals and long-term goals to try to improve the quality of life and healing for the future, not just the present. For example, some short-term goals may include reducing occurrence of diarrhea or urgency to attend your cousin's wedding in a couple of months. Maybe some long-term goals are to reduce and eliminate inflammation and maintain regular work-school balance. So there are different goals, and everybody's unique. But again, the goal here is to look at the current, not just at the current goals, but looking to the future. I must have the understanding that although we aim for the best possible outcome, we may not achieve 100% of the goal. What is shared decision making? So this is a nice survey by Dr. Corey Siegel at Dartmouth, where patients are actively involved in the medical decisions, opportunity for patients to be informed about their treatment options, be active in determining their treatment plans. The majority of patients with IBD that were surveyed and IBD physicians, by 80%, preferred a shared decision-making approach. Why? This could increase treatment satisfaction, increase confidence in treatment choice, and may improve treatment adherence. How do we engage in shared decision-making? So first of all, we need to have an open and honest communication with our doctor or provider. This is always key, but it is not always easy. Practice talking about difficult topics with a friend or family member before your appointment. So this could be if patients have perianal or a disease near the anal area, or difficulty with having a bowel movement or blood in the stool. This could be sort of awkward, difficult topics, but I think having that accountability can help before you make an appointment. Making notes of important questions or thoughts about your treatment and bring them to your appointments. If you're unsure of your ability to communicate, bring a friend or family member for support and assistance, and recognize there's more than one right way. Going back to our couple examples, look at effective partnering and treat the target. So a patient who we really want to reduce the steroids, we want to discuss steroid tapering strategies. We want to make sure we don't just stop the therapy. We want to make sure you communicate with your physician, talk about what is the safe dosage and sort of scheduling to do that so that we don't flare up with our IBD and we don't get to complications. And again, talking about the risks and benefits, a back and forth discussion of decreasing steroid use, and together determining next treatment goals. You need to have some kind of steroid sparing plan or medication that's going to help you. And number 2, the patient who's just not doing well with the Crohn's disease and needs to start biologics. So now we've got to discuss about different potential side effects and how we're going to monitor for these side effects. It may include blood tests. It may include just symptom checks. Share with your provider any symptom changes, experiences, and then test and evaluate from mucosal, right, endoscopic healing, and microscopic changes. So we need to talk about scheduling potentially next colonoscopy or even the next MR enterography or CT enterography to make sure we have objective markers of a deeper mucosal or histologic remission. and discussing these results with your provider or provider team. The Crohn's and Colitis Foundation has a number of resources available to help you and the medical team make decisions around current and future treatments. We have the IBD Symptom Tracker, which is a handout available to you free of charge from the Foundation to jot down symptoms and quality of life questions and then bring it with you to your GI appointments. There's the IBD Discussion Guide. This Foundation handout highlights key questions about IBD medications to ask your provider when discussing current and future treatments. IBD Medication Guide is a web page that lists all of the possible IBD medications and their risks and benefits to best inform you when considering a medication. An Understanding IBD Meds brochure. This is a hard copy trifold brochure that details all the IBD medications. In summary, Treat to Target is a strategy where the IBD care team and patient decide on a plan with the aim to achieve a set goal within a specific time frame. Goals are different for each patient based on his or her diagnosis and personal circumstance. To achieve the goals, the healthcare team will check to make sure the patient responds to the initial strategy at timed intervals. If there is not sufficient improvement, additional workup or evaluation or treatment adjustments may be advised. Set goals alongside your healthcare provider, both for the short term and the long term. And remember, there is an IBD Help Center at the phone number you see here, or the website, or the email, where you have trained specialists available to provide information, guidance, and support, referrals for support groups, and also virtual support groups and educational programs, free brochures and fact checks, and helping with 170 different languages. Thank you for joining us for this talk. And remember, there's additional support on the Crohn's and Colitis Foundation website.